Our final speaker for this session from our open comments is Dr. Hannah Wand, who's Director of Preventive Genomics Program, the Preventive Genomics Program, also a genetic counselor at Stanford Healthcare. Dr. Wand?
Hi. I don't know if I should be concluding, but thank you for having me. So as you mentioned, I help lead an initiative at Stanford to develop our population genetics programs. So I think a lot about the translational impact of using REA and just in general how we communicate with the public. But I am actually going to share more of a personal story on this work just to help humanize it a bit, because a lot of my personal interest in REA and how it's used in genetics is as a biracial woman with a bit of an odd upbringing. And I'll show my slide in a second to help point out some of the nuance that it takes to engage people around recruiting for research with REA, or just the fluidity and potential inaccuracy or dynamicism of REA as it's documented in clinical records and other documents, especially for people like myself that don't fit a prototype and how we've chosen to define these groups. I think it also holds true for people that are adoptees or immigrants or just other people that kind of fall outside of the norms that we've decided on in our country and in academia and medicine. So really quickly, showing this slide as a visual. So ethnically, I am Korean and Polish on paper. My mom is Korean. She grew up as an orphan in Korea, has largely distanced herself, came here as an adult, has not returned because she did not like how society treated her there. My dad is Polish. We are equally cut off from that side of the family. I've met them twice. They are aggressively Polish in a way that I realize I only am in name. It's a complicated situation. And like a lot of multiracial people, I struggle to feel like I can claim race at all, just a space for it. And I think I feel that more so without that sense of physical lineage or connection to a specific culture or even family. So I think a lot of my perceptions and relationship with REA, as I am asked about it in my clinical care as a professional, it's changed with time. It's changed based on my relationships with myself, my family. It's changed based on who I'm interacting with and what I perceive their motivations to be. And I do hope that this slide helps to show how some of that fluidity might be represented in clinical encounters. So this is a slide I used to teach. It's imagining myself as a patient being asked things and how, and I have been a patient being asked things, and how my responses or what I get assigned by others has definitely changed depending on context. So as we ask about race, and I know we're all very informed on this call and thinking about it as a social construct and very common kind of descriptors for it, as a multiracial person, it can be Asian, it can be white, it can be both depending on what's available, it can be other, it can be assigned to me based on what my provider thinks I am. It's changed from Zoom versus in person. It's been misassigned based on how my makeup or how I'm dressed that day, or geographically what's more the norm. So if you look at my medical records over the year, I'm sure there's like 10 different ways that my race has been categorized over the years. So again, race is not as concrete as people think or as stable as people think, and it can be fluid for some individuals based on the audience or situation or time. Similarly with ethnicity, thinking about it more as a cultural construct. This can also be a complicated relationship for multiracial individuals. For me, I feel most comfortable with none because I don't have that connection to either culture. Others might choose one of these other categories, but again, as my identity and relationship with my heritage and family changes, so might my answer around ethnicity. And then lastly, genetic ancestry as this very calculated thing around admixture. This is actually something as like a child of an orphan that I wasn't sure what mine was. It was a big deal when I got ancestry testing about whether my result would uncover family secrets and all this other stuff. I can now know that I'm 50-50. But just for other people where their history isn't intact, I think a lot of people think what their lineage is or think what their ancestry is based on what they know about their lineage. So when you have colonized groups, people that are orphans, adoptees, estranged families, this is not as straightforward. People might not self-report it correctly, or returning that information might uncover things that people didn't know about themselves. So for myself as a genetic counselor, and when I'm teaching this, one thing I always try to emphasize is that when we ask about these concepts, we use it as a proxy for so many other things that come up in clinical practice with genetics. And I try to encourage people to really be thoughtful about why they're asking. Are they trying to understand literacy needs of a patient where English isn't their first language and they're guessing at what that might be? Are they trying to understand social determinants of health, cultural values, health beliefs, what someone's conceptions of family are? There's a lot of things that I think REA represents to people. And because of that, it is a fluid concept when we're interacting with public. And I think that's probably, just to conclude, the last thing that I would emphasize as a concluding remark, just reminding the committee that these systems of REA are things we're walking into. It's not the other way around. And it's really admirable to be circumscribed about how we talk about genetic ancestry and to distance or silo ourselves from concepts of race and ethnicity and all of that, and lineage and heredity and lived experience. But I think for the public, that's a really impossible thing to do. And it's really difficult to erase history and to start from scratch. So I think it opens up more room for harm than good if we try to write away that complexity. And I would really consider the recommendations to come out of this as a starting point and not a solution. And yeah, I would just emphasize public engagement, science communication around any recommendations to make sure it's assimilating with society and people's ideas and things like that.
Thank you so much, Dr. Wand.